You are now listening to MedEd Talks Primary Care, a Vindico medical education production. To view CE information and claim credit, log into mededtalks.com and search Familial Chylomicronemia Syndrome, a multi-specialty guide to early recognition and novel therapies, or click the link in the notes section of this podcast. Now, here's your host, Dr. Bajaj.
Hi, I'm Dr. Archna Bajaj, Assistant Professor at the University of Pennsylvania, also the Director of Clinical Trials in the Penn Preventive Cardiology Program. This is the second in a 3-episode series titled Familial Chylomicronemia Syndrome, a multi-specialty guide to early recognition and novel therapies. For this episode, I'm joined by my colleague, Dr. Erin Michos, Professor of Medicine, Director of the Women's Cardiovascular Health, and Associate Director of Preventive Cardiology at the Cicerone Center for the Prevention of Cardiovascular Disease at the Johns Hopkins University School of Medicine. Thank you for joining me today, Erin.
Yeah, thanks for having me on your program.
Great. So today we'll be discussing strategies for accurately and efficiently detecting FCS in our patients. So Erin, I'd like to start with maybe we could just walk through the scenario of if a patient presents to you in the clinic and is presenting with triglycerides of, let's say, 1,000. What are your first thoughts when you see that patient, and what are you looking for when you're considering the diagnosis of FCS?
Okay, great. Well, first, I just want to orient the audience. What is FCS? Familial chylomicronemia syndrome is a rare monogenic autosomal recessive disease characterized by these severely elevated triglyceride levels, and it affects about 1 to 2 persons per million worldwide, and it's caused by an impaired function of the enzyme lipoprotein lipase, or LPL. LPL is the key enzyme in triglyceride metabolism, and because of limited LPL production or function, people with FCS cannot effectively break down chylomicrons, which are the lipoprotein particles that are 90% triglycerides. So to get back to your question, the clinical findings that we see in FCS are persistent severe hypertriglyceridemia, and that's defined typically in the US as levels of above 1,000 milligrams per deciliter. In Europe and other countries, they define it as greater than 10 millimoles per liter, which is roughly greater than 885 milligrams per deciliter. So some of the clinical findings that we see with FCS is that they have these persistently severe levels, and they respond really poorly to traditional therapies like fibrates, omega-3s, or niacin, because those therapies require a functioning LPL enzyme to work, and patients who have this condition don't have any functioning LPL. What we see clinically is that these patients can suffer from recurrent abdominal pain, nausea, fatigue. They can have recurrent pancreatitis, and this pancreatitis can often start at a really young age. It can become in childhood or adolescence or early adulthood. On exam, they can have eruptive xanthomas. So these are these grouped yellow or red papules that can be scattered on the arms, the legs, the trunk, or the buttocks. If somebody is willing to do an eye exam, you can look for sort of the hallmark or lipemic retinalis. Literally, the retinal blood vessels will appear creamy white because of the light scattering from the triglyceride-rich chylomicrons. The blood is essentially very milky and white, and we can see that in the retinal arteries. Patients can have hepatosplenomegaly. This is because of accumulation of fat-filled immune cells, macrophages that accumulate in the liver and the spleen. Now, we'll talk about differential with MCS, or multifactorial chylomicron syndrome, but classic FCS patients tend to be more lean. They tend to have a lower body mass index than patients with MCS, and they generally don't have other comorbidities or secondary factors, so they typically don't have, diabetes or obesity or things that might be explaining their high triglyceride levels. And they can have a family history of pancreatitis or high triglyceride, but note that because this is autosomal recessive, a family history may actually not be present.
Great. And so you gave a good description of a lot of important points to consider when thinking about FCS in a patient. Maybe just to break this down a little bit and thinking first about the labs that you might see in the patient. And so when you're talking about triglycerides greater than 1,000, I think one of the keywords you mentioned is persistent. And what are you looking at when looking at lipid levels in these patients and historic labs? When are you rechecking labs? And what are you thinking in terms of secondary causes for high triglycerides and ruling those conditions out for these patients?
So you always want to rule out secondary causes. So secondary causes of severe hypertriglyceridemia can be alcohol use, obesity, metabolic syndrome, chronic liver disease, chronic kidney disease, and or nephrotic syndrome, diabetes, particularly diabetes that's poorly controlled, hypothyroidism, and there's medications such as glucocorticoids, steroids, estrogens, immunosuppressants, sometimes beta blockers, thiazides, some of the atypical antipsychotic medications. These could all be secondary causes. So we exclude those. These patients have persistently elevated triglyceride levels. So at least 3 levels or more that are above 1,000 milligrams per deciliter, despite trying, implementing intensive lifestyle changes, a low-fat diet, and the traditional therapies like fibrates, omega-3, and niacin. Some other clues on the lipid panel. So in addition to the very high triglyceride levels, ratio of triglycerides to the total cholesterol greater than 8, that is a key diagnostic indicator for familial chylomicronemia syndrome. And these patients have low ApoB. So to orientate our audience, ApoB 100 is the ApoB lipoprotein that is on atherogenic particles like VLDL, LDL, lipoprotein little a. Whereas ApoB 48 is this truncated version ApoB that's made in the intestine and is the component of chylomicrons, which transports dietary fats. And so because this blockage of triglyceride processing of exogenous origin is so profound, these chylomicrons can't be broken down in FCS because they don't have LPL. The very minimal chylomicron remnants that are formed provide very limited lipid substrate for repurposing in the liver. So the liver is not making VLDL and LDL. So in FCS, ApoB is actually really low. The North American FCS calculator, then we can talk about that tool, but they use a cut point of having ApoB less than 100 milligrams per deciliter in FCS. Other people have suggested using less than 75 milligrams per deciliter. But the main takeaway point here is that despite these really high triglyceride levels, plasma ApoB levels are low and LDL is low. Typically, patients with FCS have less risk of atherosclerosis than MCS because patients with FCS have very low LDL. And HDL can also be low just because there's a paucity of these other lipid particles for lipid exchange, and there's increased CTEP exchange of HDL for triglycerides. So that's sort of the classic lipid panel that we see in FCS.
Great. Yes. Thanks for going through the lipid panel findings in these patients. You also mentioned the physical exam findings that you look for, the family history that might be there, might not be there, and then of course the personal history in the patient of perhaps chronic abdominal pain or repeat episodes of acute pancreatitis. So when you're thinking through the diagnosis of the patient, can you walk us through perhaps when you're thinking about using the clinical scoring criteria, and when are you thinking about genetic testing for these patients?
Sure. So the most common thing FCS can be confused with is MCS, or multifactorial chylomicron syndrome. So this is a persistent type 5 dyslipidemia that also can be refractory from treatment, because MCS also is frequently occurs from genetic susceptibility, but this is more often polygenetic risk in combination with secondary factors, as opposed to FCS, which is monogenetic autosomal recessive. So MCS is much more common common than FCS. So most clinicians will encounter this more commonly, anywhere from 1 in 600 to 1 in 250 people in North America. And the prevalence is increasing because of secondary factors like obesity, metabolic syndrome, and type 2 diabetes. And so they will have high triglyceride levels, but they also have elevated ApoB and often elevated LDL and these secondary factors. But it can be sometimes confusing because MCS sometimes can also be refractory to treatment as well because of genetic susceptibility. So there are tools we could think of. One is to refer patients for genetic testing to define their genetics. But in the absence of that, either in patients who have not been able to be tested genetically for FCS or have inconclusive genetic testing, there are some clinical calculators. The one I use is the North American FCS score calculator, which I think it can be really helpful in patients who haven't had genetic testing or inconclusive genetic testing, who have this persistently elevated triglyceride despite not being responsive to fibrates, omega-3 fatty acids, and are compliant with therapy. So I think it can help distinguish between FCS and MCS, and a score greater than 60 indicates definite classical FCS.
Great. And in our last few minutes, I wanted to touch upon the point about, where these patients might present. This isn't sort of like our other lipid disorders where patients might present classically through like the cardiology pathway, right? So, by the time patients get to you, for example, they might have already been identified as having this triglyceride disorder. But can you speak to, where patients might present if they haven't yet been diagnosed with chylomicronemia? For example, patients presenting through the emergency room because they have acute pancreatitis.
Right. So people living with, FCS generally are not presenting with atherosclerotic events. They're at really high risk of acute pancreatitis, which can be really life-threatening, in addition to having other symptoms like fatigue, severe recurrent abdominal pain. So they may be presenting to the emergency room, to the ICUs, being admitted, with pancreatitis, treated for pancreatitis. Any patient with pancreatitis should get a lipid panel. It's shocking to me sometimes where somebody's had 3 or 4 episodes of pancreatitis before they even get their first lipid panel and are discovered to have this severe triglyceride disorder. But because of these other sort of non-specific symptoms like brain fog, fatigue, they may bounce around different specialists and not get a diagnosis. And that just gets back to why this is so important to diagnose, because the burden of FCS is really challenging. It's really important to get them on the right treatment, which is an extremely strict low-fat diet, typically less than 10 to 15% of total daily calories, or less than 15 to 20 grams of fat per day, which is really very challenging. And they can't have any alcohol. So it's difficult to maintain, particularly when they're not at home. And because of the fatigue and pain, the chronic abdominal pain, this can affect their career. Sometimes they have trouble holding down jobs or working because they're in pain, or they're in the hospital with pancreatitis. And it impairs their social life. Peers often don't understand the severity of hypertriglyceride and FCS. And it's really hard to maintain the diet when they're trying to be out with, friends, have dinner outside of the home, because it's hard to meet the dietary restriction. And this can create a lot of burden on caregivers as well, and really can impact the health system. And unfortunately, physicians often fail to make the diagnosis of the disorder. And sometimes patients are frankly accused of alcoholism, or they're accused of not taking their medicines or being non-compliant because we don't see response in the triglyceride levels, or because of the psychosomatic symptoms can be a little bit vague, or they may be accused of pain seeking. So this condition, has tremendous impact on quality of life and burden for these patients and their families.
And I think what you're speaking to also points towards why not just the diagnosis, but also the management of these patients requires a multidisciplinary effort.
Absolutely. So a multidisciplinary team is really key. These patients often are followed by endocrinology, lipidology, gastroenterology, a GI specialist, often that is a pancreas specialist. We involve our genetic counselors for the genetic testing, primary care. Registered dietitian is so key. This is not a typical general low-fat diet advice. These diets are very restrictive, and it's really helpful for patients to seek help of a registered dietitian who has expertise in this condition to help plan meals and make sure that they meet their nutritional dietary needs. Often you have to regularly monitor fat-soluble vitamins like A, D, E, and K and supplement when reasonable. They also need to avoid carbohydrates too sometimes because that can get converted to fat. And so patients sometimes need to be supplemented with medium chain triglyceride or MCT oil to meet their dietary requirements. And so this can be really challenging, and we need all hands on deck. And of course, because of the lipids or risk for cardiovascular disease, they may also be encountered by cardiologists.
Great. Well, thank you, Dr. Michos, for this excellent discussion, and thank you to our audience for listening. Please tune in for additional episodes within this series. In our next episode, I will be speaking with Dr. Alan Brown about new and emerging therapies for FCS. And please remember to take the post-test and complete the evaluation to receive CE credit.
Thanks again for listening to MedEd Talks Primary Care. CE credit can be claimed through mededtalks.com. For other episodes in this series, search Familial Chylomicronemia Syndrome, a multi-specialty guide to early recognition and novel therapies.